After reviewing the aspirin video, one of our viewers asked if I would do one on the other anticoagulants. So I did. I did one on NOACs, the novel oral anticoagulants. Talked a little bit about the importance of clot prevention. And I can't believe it, I totally forgot to talk about Plavix. I got into NOACs and forgot about it. So let's go back and cover a little bit about Plavix. Clopidogrel is the name. It was approved in 1998. It was the first big generation of new anti-clotting drugs or antiplatelet drugs after coumadin. So it created major opportunities for improvement, especially in safety. At that time, it was expensive. At this point, it's about $25 per month in the U.S. Again, why do you need platelet inhibitors or clot inhibitors? Well, if you remember, it isn't the plaque that causes the heart attack. It's the clot that causes the heart attack. Yes, inflamed plaque can cause a clot. I've covered that in several other videos. Just check them out if you have any questions about it. At this point, Plavix or Clopidogrel is on the WHO list of essential medications. That means they've found that it's needed, it's necessary, it's effective, and it's safe. I have a family member who had a significant hemorrhage, bleeding problem associated with Plavix or Clopidogrel. She may or may not agree with the statement that it's safe, but again, it is safe compared to coumadin, compared to the options that we had before. And if you look at my other video on the NOACs, you'll realize there are even safer options available now. There's been some debate about whether it's more beneficial to smokers than non-smokers. I'm not going to get into that debate either. Here's the thing to know about Clopidogrel or Plavix. It has to do with genetics, and it actually opened the door for pharmacogenetic testing. In fact, even today, the major type of pharmacogenetic testing that's done is with Plavix. And why? Well, Plavix is critical for prevention of heart attack, stroke, post-stent, a bunch of different places where just aspirin alone is clearly not enough. But what we found was that some people didn't get that much of an impact from their regular Plavix dose. So here we go into the genetics, the biochemistry. What they found was that Clopidogrel is actually the precursor molecule. The precursor molecule is broken down by the cytochrome P450 enzymes. And don't drop the video just because you hear a big word. We'll go beyond that. What happened was some people don't have very active functions in that area. It's a cytochrome, it's an enzyme made by the liver, and some people don't metabolize Clopidogrel. If they don't metabolize it well, then the active metabolite doesn't go out and decrease platelets, platelet function, or clotting function. What was found actually was that those people still had 4 times the risk of a heart attack or stroke, post-event or post-stent, than people that had a different version, normal metabolizers of Clopidogrel or Plavix. So in 2010, the FDA put a black box warning on it saying, low metabolizers don't get this effect. Please be sure and go ahead and do pharmacogenetic testing to determine the dose you should give. Again, what was weighing in the balance was critical. It was a heart attack or stroke. So even today, many people would debate the statement that Plavix or Clopidogrel is probably the best balance for both safety and cost. You just need to get the pharmacogenetics. Again, the best balance in many, many situations. It's been, for that reason, it's been a blockbuster. Even in 2009, it was over $7 billion in revenue. Now, the NOACs are catching up very quickly because of some advantages they have, and I wouldn't be surprised if they pass Clopidogrel. Because what we're dealing with is far more expensive than any of the new drug costs. Heart attack and stroke, obviously, is incredibly expensive in terms of human potential, human resource, as well as just money. So there are several things that I've not covered in this series on anticoagulants. I've not covered the distinctions and debate between anti-clotting, blood thinners, antiplatelets, etc. I may in some future video. I haven't covered things like dipyridamole. It's trademarked as Persantin, and a Cochrane review actually showed it as appropriate for some types of stroke prevention. Again, I haven't covered that. What I have covered and what I want to repeat is the big deal in this whole area. Less than a third of the people that need these medications are actually taking them. Again, when there's a problem like that, everybody wants to throw blame around. Patients want to blame docs. Docs want to blame patients or whatever. Let's just fix the problem. Be aware. If you have had a stroke, if you've got atrial fib, if you've got some of these other major indications for need for blood thinners, clot busters, or clot preventers, antiplatelet drugs, whatever you want to call it, please consider that strongly. It's easy to be afraid of a medication because of the dangers, but it's also easy to forget about the dangers associated with not taking those medications.